to record the session. Secondly, whatever is going to come ahead, in this session has been verified by medical registrars and lecturers, so you don't need to worry about the authenticity of it. It might vary a bit with the current practice. It even varies between units. So, I'm not going into those details where the management differs to that level. I'm just going to give you the understanding of what you as a junior doctor need to know for you to thrive, or make the most of your time as an intern or medical student when you go for rotations. Uh, Now they're going to be blunt, and there's what you'll be learning today is basically, first of all, the basics of ECG, and then we're going to move on to the most common ECG encountered as an intern or a medical student, and what you should do about it. So there's been cases where even as a medical student, some persons found out about an ECG change, which even probably the medical JR1 did not understand, and they started off a medication on it. So there's a lot of things you can do, because quite often it's the simple things that you tend to forget and overlook. Now, the first 5 to 10 minutes are going to be a bit of a bore, probably because you know all of that stuff. I'm just going to go over them quickly, so you're revised for the session ahead, because that's when it gets fun. That's when you start. That's when we'll start trying to identify what's going on, and try and diagnose ourselves. So, come on, we should start now. Perfect. Okay. So, um, let's get started. Okay. The ECG. I'm just going to run through this because you guys all know this. Basically, there's two types of leads, right? You have the bipolar leads and you have the chest leads. And one of them looks at things in a frontal plane, where you're looking at the body. If you cut it across the coronal plane, the chest is identified. The areas of the chest are identified in that plane. Whereas the chest leads are a transverse section of the heart, so you identify exactly in that circular transverse section where which part of the heart it's detecting. Uh, Now, if you look at the placements here, the lead placements here, right? You basically have AVR, AVL, and 1. Now, you need to remember this. It's easier that way, that AVR, AVL, and 1 are leads which look at the anterior walls and the anterior and left wall, right? It gives you a frontal view of the anterior wall of the heart. And the leads 2, 3, AVF are placed in a way where they give you information about the inferior walls of the heart. Moving ahead, horizontal plane view, you all know V1, V2, V3, V4, V5, V6. You know where it is placed. It starts off on the right side of the sternum and progresses to a transverse in a coronal plane across the chest. So and gives you information about both of them. Yeah. So an integrated view of the ECG chest leads is important, because that gives you an understanding of what lead is placed where and how we can combine two leads to identify which location has a defect or an infarct or anything else, right? So if you look at AVR, AVL, and 1, like I just said, they give you a coronal section of the heart. You understand where the deficit is in a coronal view. Now, if you add that to the transverse section view of the chest leads, which is V1 to V6, you get an exact location of where the defect is. Now we're going to come back to this when we're solving ECG questions. So I'm just going to quickly go ahead. Okay. First of all, we're going to start with the basic stuff. We're going to start with atrial enlargement. Okay. Atrial enlargement, you guys know, right side, left side. Right side, what you're going to see is there's a significant increase in the P wave, which would be more than 2.5 mm. Now, essentially 2.5 mm is basically two and a half small, boxes. So if you look at this ECG, the P the P waves here are significantly increased, almost reaching to the R of the QRS complex. And that indicates that there is a right-sided involvement of the atrium, which has increased in size. Now, can somebody tell me which is the most common cause of right-sided atrial enlargement? There's like a lot of them, but just one. Eventually, it comes down to just one mechanism. Which one do you think it is?
Mitral stenosis.
That's left. You're talking about the right. Anybody? So which atrium is connect? Which deficit is going to most cause back pressure on the right atrium?
Tricuspid
So the most
stenosis.
yeah. So tricuspid stenosis is one of the reasons, definitely. Now it eventually everything comes down to pulmonary hypertension. Pulmonary hypertension, most commonly due to cor pulmonale or tricuspid stenosis, secondary, is going to cause right-sided atrial enlargement. Now, this is very common in patients who come in with some sort of chest disorder, but then you see this on the ECG, and then you know that that chest disorder has eventually led to the back pressure being created in the right side of the heart, and effectively right-sided atrial enlargement. Okay, so the most common cause, if you're asked in an exam, is pulmonary hypertension. Okay, just a minute. Yeah. So, talking about left-sided atrial enlargement, you all know that the most common cause, like Samiksha just said, I think, is mitral stenosis. I'm not going to discuss that, but let's just consider the P wave. Now, this is where things get interesting. You know, the classical, the biphasic P wave, which you read in textbooks. It's quite common, actually. It's usually not seen. So the sensitivity of it is just 50%. So only 50% of the people who have left-sided atrial enlargement are going to have this sort of a typical biphasic, this curve out here on lead two. But if they have it, it means that almost certainly, which is 90% surety, you can say that this person has left-sided atrial enlargement. And ideally, whenever you're talking about changes in size of the atrium, it's very important to say enlargement and not hypertrophy, because quite often uh, understanding the difference between enlargement and hypertrophy on an ECG is extremely difficult. Even, I mean, it's sort of difficult even for experts to gauge that. So it's best if you stick to the nomenclature of saying enlargement. Now, what if you have both of them positive, right? So if you have both the right-sided and left-sided atrial enlargement, then you have bilateral bilateral engagement. So essentially, you're going to have a tall P wave along with a biphasic P wave. Now, it's quite rare for this to happen. It usually happens in congenital heart diseases where the back pressures along with multiple sort of cardiac anomalies have contributed to the enlargement on both sides. And it's rare for an intern to or you as a medical student to be asked to identify this, and just saying it out for general information. Okay, quickly moving on to ventricular hypertrophy. We all know how to identify ventricular hypertrophy. We generally were taught the age-old mechanism where we look at leads one and AVF. One and AVF, if you say it says left leaving, so it basically means that in cases of left ventricular enlargement, you're going to have one and AVF going apart from each other, and right reaching, which is in right enlargement, you have one and AVF reaching towards each other. There's another way of looking at it, which is a more standardized way, where you exactly calculate if there is an enlargement. There's a Stanford method. There's multiple two, three other methods which you don't need to go into. Just remember whichever one you find comfortable with, because eventually in the exam you're just going to be asked how you did it, and they don't really care about the mechanism, the sort of the which formula you used for it. So usually in the normal pattern of things, you will see if you put all the V leads together, you're going to see a very gradual change from a deep sort of S wave to a tall R wave. Then you're going to, if you have a left ventricular enlargement, obviously the amplitudes of both V's and V1s and V6s is going to increase. So effectively, the total will be greater than 35 mm. Uh, you guys know the causes, which is P mitral and left axis deviation. And right ventricular hypertrophy, you're going to have a complete change in the where RV1 is SV6 going to most commonly in P tail and right axis deviation. Okay, so now this is the fun bit. Okay, so we're done with all the boring stuff. We're done with all the discussions of things you already know about. Bundle branch blocks. We're going to start off with that because quite often what happens is that bundle branch block is extremely common. It can occur isolated in an isolated manner. It can occur with an MI. It can occur with a lot of other heart problems. And quite often what happens is that you see it and you're a bit confused because the QRS doesn't look the same. The other leads don't look the same, and then you don't know what it is. And you try to look for signs in places there aren't. So bundle branch block is I feel less represented and less taught to medical students and interns, but it's quite important because it indicates a lot of other things we'll talk about. Now, how do you diagnose it? There's only two steps in it. Okay, first you need to look at the QRS complex. Is the QRS complex greater than three small blocks, which is basically greater than 0.12 seconds? And you need to look at the pattern. The pattern has a very simple mnemonic. The pattern in V1 and V6. So the mnemonic is William Marrow. William Marrow stands. So in William, you have LL in the center, which indicates you're looking at a left frontal branch block, where the V1 is going to be a W-shaped QRS complex, and a V6 is going to be an M-shaped QRS complex. Let's look at the example here quickly. So if you look here, first of all, what is the first rule was that your QRS complex needs to be greater than three small blocks. This is definitely greater than three small blocks, and therefore it is greater than 0.12 seconds. Next, the problem with the left bundle branch block is that the W here is really not that distinct. Like you can't really make out if this is a W or not, right? But the M here seems to be distinct, that you can see this sort of M pattern, right? This pattern. This is an M. So instead of understanding if there's a W or not, you first look at if there's an M. If you see that the QRS complex is big and you see that there's an M pattern, you just see if there's a small. This pattern is called an small r S pattern, right? Which is basically equivalent to a W pattern. The left bundle branch block is therefore one of the most important ones because you can have it either in a chronic state or an acute state. Now, the most important thing you need to remember here is that if it's an acute change, so for example, you have a patient who's admitted and you've seen the worst patient's ECG, say for example, a year, an hour ago. Okay, you went to take bloods and you just wanted to go through the file, so you saw an ECG, and the ECG seemed okay, right? Then probably after half an hour or an hour, the patient starts gasping. He says he's probably a bit breathless, or he's having some sort of chest discomfort. You ask somebody to take an ECG, and you look at the ECG and you see that there's an increased QRS complex. It's greater than three small blocks. Then you look at V6, it seems to be an M. And then you look at V1, it seems to have a smaller S pattern, which is equivalent to a W. So then you know that this is a left bundle branch block in an acute setting. And therefore, this is diagnostic of MI. You need to immediately thrombolize, right? But if the patient is admitted, patient is all right, patient has previous records, he's sitting out there, and you see a left bundle branch block, right? We all know how to diagnose that now. You're going to diagnose him as somebody who either has an aortic stenosis or hypertension. Now, the mechanism of this is a bit complex, but essentially what you need to remember is that effectively the hypertrophy of the ventricles, which happens in these conditions, damages uh, the the branches to an extent where it gives you a pseudo left bundle branch block appearance on the ECG. Okay. So has everybody understood how to diagnose left bundle branch block? So we can move on to right bundle branch block, which is super easy. Left bundle branch block is what you're going to see 80% of the times in the wards if somebody has a block. You're rarely going to see a right bundle branch block. And it's going to be even rarer for the right bundle branch block to be an emergency, which you should have identified. You're not going to regret not identifying the right bundle branch block. But a left bundle branch block, you need to know. So has everybody understood left bundle branch block? How you're going to see it and how you're going to diagnose it? Because everything else in this ECG seems all right. It's just there's a deep QRS, which is also indicative of an MR of an MI. So just let me just quickly give you this. This is a deep Q. This is a deep Q wave. This is a deep Q wave. This deep Q wave is indicative of a of an MI as well. We'll discuss that going ahead. But basically, you're going to look at this. You're going to see, for example, you're going to see all the other things in the LVB, and you're going to diagnose LVB. You're going to see if it's an acute or if it's a chronic LVB, and accordingly manage it. Now, right bundle branch block, like we said, the mnemonic is marrow. So marrow, like you guys probably study from that a lot these days. So the RR stands, it's telling you it's the right, it's telling you that this is for the right. The mnemonic is telling you itself, and the M is you need to find the M in V1, and you need to find the W in V6. So let's just look at this. Okay, it's going to be very easy. Again, first rule of bundle branch blocks, the QRS complex needs to be greater than 3 small blocks, which is 0.12 seconds. And the second rule is identifying what pattern there is in V1 and V6. Now, looking at V1, it seems to be an M pattern. And looking at V6, it looks like a W pattern, right? So, I mean, let's just draw that again. So, it goes up, down, up, right? And W out in V6 is going down, up, down. So this looks like a W and an M. Again, look at this ECG. You see that the QRS complex is big. It's big, it's big, it's big everywhere, right? So here you're going to, it's very clear out here that this is an M pattern. It's very clear out here that this is a W pattern. The RBB is really not something which you're going to encounter daily, and it's really not something you need to worry about. But it's good, since you know left bundle branch block, it's very easy for you to remember the right bundle branch block, right? The most common causes of this is, again, MI, pulmonary embolism, or right ventricular hypertrophy. Like I said, when you hypertrophy something, there's a pseudo bundle branch block which is created because of the tension which is caused on the bundles. Okay, the big one, MI. Everybody needs to know how to diagnose an MI. I mean, you cannot call yourself a doctor if you do not know how to diagnose an MI. I have had patients during my first posting as an intern die because I was sitting in a periphery casualty and I just didn't know how to diagnose it. So we were dependent on somebody who was sitting in the ICU somewhere else, and they probably did not know how to diagnose it. So I'll tell you a story about it later on. But essentially, I feel that nobody should be allowed to practice if they do not know how to diagnose MIs, because that is one of the most important thing you can do as a doctor, to identify and ask somebody to start treating for an MI. Now, you need to know what the timeline is when you're looking at an MI, because usually when you think of an MI, you only think about ST elevation or non-ST elevation MIs. But it's usually what happens is that MIs don't always have an elevation or a depression when you're looking at them. When the person, if for example you're sitting with a patient, you're probably drawing bloods for a patient in the ICU, and the patient he's connected to an ECG monitor, and it's going all right, and then suddenly you see hyperacute T waves, like really spiking T waves. It's just going like this. Okay, that's a bad QRS complex. So P wave and then QRS, and then you see like spiked T waves, like sudden spiked T waves, like going like that, suddenly coming onto the monitor. Your first suspect should be MI. There's a lot of other things which can cause this. There's hypokalemia. There's the other electrolyte anomalies which can cause this. But when you're talking about it in a sudden manner on a screen, you need to think about MI. Simple. Seconds to minutes, the onset of an MI, you're going to have T waves, hyperacute T waves. Then you're going to have ST elevation. Yeah, that ST elevation stays around for a while. Then within 24 hours, you're going to start noticing T wave inversions. You're going to see new T wave inversions. So this can also occur in persistent IHD and ventricular hypertrophy, but you should always be cautious if somebody is telling you that they had chest pain and they had and you can see that he has a previous ECG, probably that was for acidity, but now he's come in with chest pain again, or maybe he had chest pain a while ago, and now you take an ECG, you see that there's an inverted T wave which was not there before. It indicates that this person at some point today or yesterday has had a small, if not a big, a small MI. So you need to start them on MI medications like anticoagulants, etc., depending on the situation. But don't rule him out as just acidity if he comes in and there's no ST elevation, right? Now, this is uh, I think we're running short on time, so I won't tell you the story. It was a really sad story on my first day of internship where a guy came in with T-wave inversion and he didn't have ST elevation. So one of the doctors just sent him home, and on his way back he collapsed and passed away before he could get back to the hospital. So that was one of the wake-up calls for me to like really understand ECGs, go into the depths of it. Inverted T waves can also stay up to months. So that's why that can confuse doctors as well. Now, pathological Q waves are important because, like I just said before in our LBB, pathological Q waves are an indicator of previous MIs as well. So essentially, deep Q waves are wide and deep. That's all you need to remember, right? So Q wave is immediately after the P wave, and if this is deep, it's pathological, right? This is not the normal size of Q wave. The minute you see it, you know it, right? Now, I want to ask you guys a question. It's a very interesting one. If I've just told you a bit about MIs, not a lot, but since you guys know about ST elevation and everything, can you tell me what this ECG is? Of course, it's an MI, but what is this a new MI? Is this an old MI? What is it? There's arrows marking out here which give you hints about what it could be. So can you tell me if this is a new MI or an old MI? Pathological QAs usually occur after days, right? So what do you think this is? Okay, Zoe says healed MI. Interesting. What else? Anybody else has anything to add? What it could be? Samiksha? Okay. Mm, does lead 3 show ST elevation? Yes, it does show ST elevation. So, uh, what do you think it is? Okay, I'm just since we're running short on time, ongoing MI. Samiksha says ongoing MI. So putting all your answers together, that's the correct answer. This is basically what you'd say, since this is like I said, pathological Q waves occur after days. So this is indicative of an old MI, and the current ST elevation you're seeing is indicative of a current MI. So this is an MI which is occurring right now, but the patient has also had an MI in the past few days, 2 months. So this is an old plus new MI, right? Okay. So let's move on to the important one, like localization of the infarct. This is where you get your brownie points in exams, practical exams, final year practical exams. This is if somebody asks you which type of MI do you think this is? Where is this MI located? What if you had to do if you had to do percutaneous pulmonary coronary intervention, which vessel should you go into? If that sort of question comes around and if you answer that, I mean, there's nobody who can stop you from getting a distinction probably. Uh, okay, so quick revision again. Anterior wall. What did we say anterior wall was? Anterior wall is AVR, AVL, and 1. Inferior wall is 2, 3, AVF. If you had to look at the heart in this sort of a manner, in a cross-sectional manner, AVR, AVL, and 1 are in that sort of frontal plane, and all the chest leads are V1 to V6 are in the transverse plane, right? So AVR, AVL, and 1 are looking at the frontal plane. This is looking at the inferior wall of the heart, and the other chest leads are looking at the in the transverse section. So blood supply of this entire sort of system can be simplified into 3 sections. Yeah. So this is, let me just give you this is anterior, this is posterior, this is superior, this is inferior. Okay. Now, if you look at the anterior wall, this anterior wall is supplied by the anterior descending branch of the left coronary artery. Simple to remember, right? Anterior descending branch of the left coronary artery. And the inferior wall is supplied by the posterior descending branch of the right coronary artery. Okay? Because you know that the right coronary artery supplies the base of the heart. Now, if we merge the leads, the ECG leads, and these vessels together, we know that the anterior wall is supplied by one AVR and AVL, right? And if you look at the transverse section, then V1 to V4 are usually associated with this anterior section of the heart. The posterior branch of the inferior wall of the heart is supplied by 2, 3, and AVF, like we discussed before, right? They're just placed that way. They're just placed towards the bottom of the heart. So essentially, they give you information about the base of the heart. Looking at the posterior wall is supplied by the left circumflex branch of the left coronary artery, right? And this is represented by V1 and V2. Now you need to remember that V1 and V2 do not directly represent the posterior wall of the heart, right? It's going to show reciprocal changes. So for example, if there is ST elevation in other leads, then V1 and V2, if there is a posterior infarct, is going to give you an ST depression. So that is how you identify it. And if you see the intersection between the anterior wall and the inferior wall, this is supplied by V5 and V6. Okay. Does anybody have any questions here? Because if you understand this, you literally understand any ECG. You don't need to remember mnemonics and stuff like that. You only need to remember that these three sections of the heart is supplied by these vessels, and the anterior section of the heart is represented by one AVR AVL, and the base is 2, 3 AVF because of the placements they have. And V1 and V2 represent the posterior part of the heart because they will show reciprocal changes since they are aligned that way. Does everybody understand this much? Then we'll go on to like questions about it. Yeah, V5 and V6. Okay. So when we're looking at the heart, let me just take you back to the orientation. When we're looking at the heart, we're looking at V1, V2, V3, V4, right? This is the anterior. If you can just see it, this is the anterior. This gives you information about the anterior heart in a transverse section. If you look at V5 and V6, this gives you an understanding of the apex and the sort of anterolateral part of the heart when you look at it in the transverse section. Now, when you go here, this is sort of the apex region, right? This is the apex region. And the apex region has supply from both vessels, which is the anterior descending branch of the left coronary artery and the posterior branch of the right coronary artery, although the majority comes from one of them. Now, that's why when you're looking at the apex of the heart, V5 and V6 are the best indicators of what is going on at the apex. It's not the only indicator, but if you want to see if you have only V5, V6 elevation, you know that this is probably an end artery apex damage to the heart. Does that make things a little bit clearer? Okay, great. So now, for example, can somebody tell me how you would how the septal MI would look? So obviously, an MI in the septal region would be here, right? So this is if you can't get oriented to what this is basically the heart. You're looking at from the top. We've taken a transverse section of the heart, and you're looking at it from the top, right? So the septal MI probably occurs here, and therefore you're going to see changes in V2 and V3. Slight changes, not a lot, because septal is usually it's a bit deeply located, so you're not going to see significant changes. But V2 and V3 are where you're going to have to look at. If you see changes in V1, V2, V3, it means that the septum has been damaged and a significant part of the anterior wall has been damaged. And therefore, you are seeing ST elevations in V1, V2, V3. Therefore, you will call this MI an anteroseptal MI. What about anterolateral? So now we know when you say antero, V1 is involved. And if it's obviously not going to be something which is just around V1 and then V4, V5. It's something which is going to be involving the entirety of the anterolateral aspect of the heart, probably not the septal region, right? So in this case, you're going to see ST elevation in V1, V2, V3, and V4, ideally, right? Lastly, an extensive anterior wall infarct. This is usually the patients who come in with very, very, very bad morbidity profiles. They probably aren't going to survive things. If you ask the resident what does the MI indicate, what is the prognosis of this patient, the resident is probably going to be like, he's not going to make it. This is the kind of infarct where a large significant amount of the muscles which are involved in the majority of the pumping of the blood are involved. So the extensive anterior wall infarct is defined as a place where all your leads from V1 to V6 are involved. So let's just do a quick recap. If you say a septal, we're looking at V3, V2, V3. If you're seeking an anteroseptal, V1 is involved. V1 is the important thing when you need to consider anteroseptal. When you're talking about anterolateral, it means that this extends from the anterior, which is V1, to approximately V4. And extensive anterior wall infarct is something which involves the entirety of your chest leads, which is V1 to V6. Okay, so let's do a quick recap of how you're going to approach an MI. If you look at an ECG, how you're going to approach an ECG, which probably looks like an MI, right? So first of all, like I said, you need to identify which plane you're working with. You need to first identify where it is in the frontal plane, and then you need to identify where it is on the transverse plane. If you identify these two, like a 3D graph, you know the exact pinpoint location of where the MI has happened, where the infarct is. So first of all, you're going to look at leads 1, 2, 3, and AVL, AVF. You're going to identify which plane it is in. Is it in the uh, anterior frontal plane, or is it in the inferior plane? Inferior plane essentially means AV, AVL 2 and 3. Sorry, AVF 2 and 3, and your anterior wall would be 1, AVR, and AVL. Cool. Once you have that identified, you're going to look at the chest leads, which is the transverse section. And then the chest leads, as we discussed right now, is going to give you the extensiveness of the infarct to the extent where you know if this is anterior or inferior. And then once you know anterior and inferior, you know if it is septal or lateral or extensive, right? But if you feel like you're one of those people who needs something to remember for the exams and can't really sit and go through this whole process, you can just quickly, there's this cheat sheet which is available. I'll be sharing this whole notes document with you after this session is over, and you can just remember this. It's a very simple understanding of which arteries are involved in which leads. So wherever you see the ST elevation, you just need to remember which arteries supply which leads, and you can answer that question quickly. Just for just as an interesting case, which I recently saw, I'm going to tell you about triple vessel disease. Triple vessel disease is like this case where you're like, this guy, he's going to need like the top of the line care to just save his life, and probably even that's not going to be enough. So if a patient comes into you, right? So you're seeing, so you see here, you see here, you're seeing an ST depression, ST depression, ST depression. So there's ST depression all around. So this guy definitely has an MI. Now, what kind of an MI does he have, right? If you look at it, you're going to have to look at 1, 2, 3, 4, right? So in this general picture of the chest leads, you know that this is the frontal plane, but it's also involving AVR, right? So and AVF as well. So you know that it's involving both the anterior and the inferior walls. Now, looking at the chest leads, it involves V2 to V6. It means that this is pretty much an extensive involvement of the heart muscles. So what all is involved here? I mean, frontal plane and inferior plane are involved. So it means that you have the right coronary artery which is involved and the left coronary artery as well. So ST elevation in AVR indicates the left axis, the left anterior descending artery involvement, and V2 to V6 involves circumflex arteries. Now, I don't really expect you guys to completely understand this, but if you can remember these two criteria, it's a good question to be asked in the exam, and if you answer this, it's all brownie points from there. So I'd suggest that you take a look at this, go online and check other examples. It's a pretty interesting case which I was able to diagnose just recently. So, okay, now management. You guys, I think you guys have all, if you've done Quest or I don't know if you're doing Quest right now, you guys know this. It's very simple. Uh, there's a lot of examples which you're taught with. Essentially, the simple thing you need to remember is that percutaneous coronary intervention needs to be done within 12 hours of onset, and that too within 120 minutes from where fibrinolysis could have been given. So fibrinolysis can be given within 5 minutes of the patient coming into the hospital and an ECG has been taken, right? So if you know that your cardio department is able to do a PCI within 120 minutes, which is 2 hours of the patient coming in, you're going to put this patient for a PCI only. If you know that this patient is not going to be able to get to a PCI, then you will start with fibrinolysis, which is given free of cost. Ideally, streptokinase is given, and if that is not available, if you need to get drug from outside, it costs a lot of money. So in a hospital like KEM, this is given free of cost. Although, you might be asking, why can't we just give both? Why can't we just start with fibrinolysis and and give PCI later on? And technically speaking, that is actually the practice which is done in a lot of countries outside of India, usually the first world countries, because you have adequate supplements and adequate personnel to monitor the patient if you give both these treatments, because both these treatments given together have a high risk of the patient bleeding out, and you don't want that. But usually this is a standard of care outside of India. But in India, usually uh, you need a very definitive understanding of what treatment needs to be given, because if you give both and the patient goes bad, there's very little you can do. Okay, so Dessler syndrome. When a patient comes in, he's had an MI. He comes in, say for example, 2 to 4 weeks later, and he's having fever, pleurisy, chest pain, and you do some blood examinations. His ESR is high, and you do an ECG. There's very little changes in the ECG, just a chronic, MI change, probably a deep Q wave. You know that this patient is not in acute distress. It's not an acute MI. What do you think it is? It's called it's this is when you say that the patient has Dessler's syndrome. Dessler syndrome is it's actually pretty common. Patients do come in and you feel that it's a repeat MI, but it's usually not. The pathophysiology is essentially that there's auto antibodies which is formed against the dead myocardium, and this is what's causing all the inflammation, leading to fever, pleurisy, pericardial effusion, and an increased ESR. Right. The treatment for this is reassurance and prolonged NSAIDs, which need to be prescribed. This brings down the overall inflammation, and towards the end of it, the patient does recover, but there are high chances of fibrillar attachments which happen in the pericardial tissue, which can be monitored later on. I'll tell you about the ECG findings at one point. Okay. This is the last important point which we're going to discuss today, because beyond this, everything is going to be a quick quiz. VTAC. VTAC is probably the one place where you can shine as an intern individually as well. This is where if you're sitting by a patient and you put in an ECG machine, you connect that patient to an ECG machine, and you see these waves, and you're able to diagnose them. You can yourself administer what needs to be given, and call in a crash cart and do the uh, DC shock, or whatever. Whatever you feel is the right approach to it, because this is one of those cases where this treatment is straightforward. The only problem is identifying it. Right. So VTAC is ventricular in origin. It's usually post MI, where there's circular circuits being formed because of dead tissue. The heart rate is extremely high, 250 beats per minute. There's two types. Monomorphic, which you've probably seen, they just go up and down, up and down, up and down. It's just like there's just R waves. You just feel like there's just R waves all around. Right. It's just the same sort of R waves again and again. Then there's polymorphic. Polymorphic is divided into two types again. There's normal polymorphic, which are just, they're just randomly shaped. Their amplitudes are changing again and again. So for example, if you look here, the amplitude is changing, the amplitude is changing here, the shape is changing here. So you just don't really know where this current is coming from. Usually this progresses into torsade de pointe. Torsade de pointe is basically French for moving between a point. So it forms spindle shaped amplitude changes, right? So Right now the amplitude is low, then it gets high, then it goes low again. But it's basically pretty similar to a monomorphic ventricular tachycardia. This usually progresses into ventricular fibrillation, which is basically just this. There's almost no activity, just randomness all across. Now, can somebody quickly tell me what the difference is between polymorphic ventricular tachycardia and VFib? I mean, what could be the difference between polymorphic ventricular tachycardia, any of these, and VFib? Ooh, anybody? Okay, I mean, I'll just quickly go ahead with it. Polymorphic ventricular tachycardia is essentially where even though you have ventricular tachycardia, you can see random, fluctuations, and they don't really seem to align with anything. The amplitude changes, the duration changes. But the most important point here is that there is pulse felt. Pulse. This is where the difference comes in. Right? Ventricular tachycardia means the ventricles are still pumping adequate amount of blood, where some amount of perfusion is happening. Whereas ventricular fibrillation leads to the ventricles not being able to pump blood for any sort of any sort of blood supply to any organs. So therefore, usually pulse uh, uh, pulse is negative in these sort of situations. Okay, ventricular tachycardia treatment. You see that the patient is not responding. You quickly grab an ECG machine. You hook on the ECG machine. You see ventricular tachycardia happening. It's not yet fibrillation. What do? If the patient is stable, usually these sort of patients are admitted and they seem to be stable. It's usually a monomorphic ventricular tachycardia. In that case, you're going to give 300 mg of amiodarone. And if that fails to do anything within the next 5 minutes, you're going to give him a DC cardioversion of 100 to 360 joules. Ideally, you start with 100 and then you ramp up with every successive shock if there is not restorement of normal ECG. If the patient is unstable, the patient is not responding, the patient has collapsed, his pulse is not felt, etc. If his pulse is felt, you know that you can still sort of go for a medical management, which is amiodarone 300 mg. Whereas if the pulse is not felt, you need to do immediate defibrillation because this patient is not being perfused in the brain in other vital organs, and without the restorement of normal ECG within the next 1 to 2 minutes, this patient is at serious risk of dying. So again, the defibrillation is going to be 100 to 360 joules. If you see a toss at the point, you will add MgSO for the treatment routine, but MgSO4 has a very complex calculation for what dosage needs to be given. So ideally, it needs to be given by a resident. So this is not somewhere you will be involved in the patient care. But yes, giving DC shocks is part of an intern's. You could be asked to do it. You might be the only person towards the head end where the machine is. That's how I got to do it a couple of times. It is pretty much like they show it in the movies. The patient does jerk. You do need to look at the ECG every time you give the shock. You do need to hope to God that the ECG goes back to normal. And the failure rate is quite high because once the heart has entered into a VTAC sort of situation, it's difficult to get out. Okay, so this is where I need you guys to be involved. If you guys get this, the rest of the lecture is just it doesn't matter because if you get this, you're pretty much ready, right? This ECG number one, what is the diagnosis? We're just talking about ventricular tachycardias here. I want to know monomorphic, polymorphic, tosses the point, ventricular fibrillation. Which one is it? Okay, which one is it? Okay, yeah, Shri Vaidya. Monomorphic, Samiksha. Mono. Yep, perfect. Perfect. Simple, right? It's mono. You can see it very clearly. It's just one shape. It's going up and down again. Just seems like repetitive R waves. That's it. Okay. Number two. What do you see in this? Now, this is a bit, I've given you hints here because this is a bit, uh, you know, it's stretched out. So think about it. Okay, I see VFib, V torsades, VFib. Okay, VFib. Okay, okay. So This is actually all of this. So this is one of those rare ECGs in action where you're seeing torsades here, right? So it's forming this bell sort of curve. So this is torsades, and this is entering into VFib. So this is torsades here, and this is VFib. Like I said, if you remember what I said here, torsades usually progresses to ventricular fibrillation. So it's very important that you monitor anybody who is on VAC because they can progress into torsades and then eventually in VFib. Now, I've put a question mark down here. What do you think this is? What do you think this is? And why is it not aligning with the upper ECG? So like, for example, here you have torsades, but here you're seeing VFib, right? So this is what is called as a separate running ECG, which is taken successively after the change happens from torsades to VFib, right? So we need to also understand that torsades and VFib can alternate between each other. Torsades can go into VFib and VFib can go back to torsades. And it's important because the treatment protocol changes very easily with these. And therefore, once you get this change from torsades to VFib, you need to take a running ECG of lead 2 or whichever lead, but ideally lead 2 is taken, of the ECG which progresses beyond torsades to VFib conversion. So you understand if it's a stable VFib or if it's an alternating VFib. Okay, the next one, diagnosis. Can you see it? Not sure. What's the diagnosis here, guys? Quickly. Um, so I got an RBB. Okay, next. Okay, I'm just going to quickly tell you guys this is so let me just clear this doubt about it being RBB. This is I got a mono. Okay, so let me just clear the doubt about this being an RBB. This is not an RBB because see, like I said, an RBB is basically where your ECG just looks normal, right? It looks like this. It's just that your QRS complex is greater than three small blocks, which is basically greater than 0.12 seconds. Everything else is the same. It's just first you need to look at the QRS. You need to know that ECG just looks the same. There's no significant difference. And then you look at the pattern in V1 and V6, right? This here, all the leads have significant changes. They look like they're just ventricular in origin, right? There is no QRS complex. There is no P wave. There is no T wave. It's just random R waves. But here, if you look, the the changes are happening, right? So this is the answer for this is mono. This is because it's all the same. It's all R waves. It's repetitive. There's no change in amplitude. Here, this is basically this section of the heart. If you're wondering, is basically just the heart's attempt to go back into natural rhythm. But like you can see, it's not being very successful at it. So it's quite likely that going ahead, it went back into mono after this till treatment was given. Okay, number 4. This is simple. Quickly, you can just look at it and you know that this looks very physicsy. Yep, this is torsades. Torsades. Yep, see this fluctuation, see this fluctuation, see this fluctuation, see this fluctuation, torsades, right? Okay, last one. Last one. VFib. Perfect. VFib. Okay, so you guys have a pretty good orientation of what ECGs are. I am just quickly going to tell you what cardiac arrest has it can have an entire 1 hour session on its own because there's just multiple. It's cardiac arrest is the most common sort of patient you're going to see sitting in a casualty because uh, per night you're going to have patients who are being brought in dead and you need to do an ECG which is flatline. Quite often there's nothing you can do. Quite often, sometimes you will find that they have something which is called pulseless electrical activity, which is a different condition which you need to approach differently. And sometimes you're going to have patients who are going to be in VTAC if they're brought in early or VFib. That is, the treatment for that now. Ideally, if you see a patient who's admitted in the ward, he's a monitored patient and goes into cardiac arrest, which is basically flatlines. You need to give three stacked shocks, which is basically 100 to 360 joules of DC cardioversion. CPR initiated for 2 minutes with 1 mg of adrenaline every 5 minutes given. That's the basic protocol. That's what you need to know. Now, before what used to happen is that if the patient is intubated in the ICU, they used to give trickle drugs, but this is not recommended anymore because it has a very variable onset of action. And that's not what you want in an emergency situation. Atropine is also something which even now you will see residents give, but it's ideally not supposed to be given because it interacts with the other management drugs of antiarrhythmic origin. So in case you need to give antiarrhythmic drugs later on, having given atropine will cause issues because it's going to push the heart back into arrhythmia. Ideally, ALS needs to be initiated, and the patient, if he comes into the casualty with VFib or VT, you need to give one shock, then start CPR and adrenaline. And the treatment for VT, like I told you, is amiodarone if he's stable with concentration of 300 mg. Atrial fibrillation, atrial flutter, you guys know this. I'm not going to go into this because the patient ideally never is unstable with this. You have seen a lot of ECGs with AFib and atrial flutter. Atrial flutter will have the typical, chainsaw sort of appearance, and AFib is basically no sort of activity in the atrium, and then QRS complexes at a very high rate. Uh, the management will depend on if the patient is old or young. If the patient is old, you'll ideally go for rate control because it's very difficult to bring their rhythm back. And if the patient is young, it means that it's some sort of paroxysmal atrial fibrillation. So you can try and get the rhythm back into control. If the patient is unstable, obviously you need to do DC cardioversion immediately. So here's a question for you guys. Uh, I'm pretty sure you guys know Wolff-Parkinson-White syndrome. And why is Wolff-Parkinson-White syndrome and if the patient requires if atrial fibrillation life-threatening? Can somebody quickly just answer that? You get a lot of brownie points for this answer.
The atrial impulses will pass on to the ventricles and it'll lead to VFib. Uh,
Perfect.
like yeah.
Perfect. Yeah. So Wolff-Parkinson-White is basically a situation where you have an anomalous pathway connecting the atria and ventricle. It can be on the left side or the right side. The treatments are different. The VCGs are different. You don't need to know that. It's a high level concept. But what you need to know is that if a person who is already diagnosed with Wolff-Parkinson-White syndrome and is currently on treatment and develops a new AFib, you need to immediately treat this patient and cut off this connection by there's basically you need to do a laser photocoagulation of that pathway, which is done by cardiologists. If not done, the atrial fibrillation pulses are going to be stimulating the ventricles at the same atrial fibrillation rate, and the ventricles are also going to go into fibrillation. Now that's the huge difference, right? So atrial fibrillation is not life-threatening, but ventricular fibrillation is life-threatening within minutes. That's why any sort of atrial fibrillation in any level of Wolff-Parkinson-White syndrome needs to be immediately looked after. Okay, so PSVT. This is one of my favorite ECGs because this is one of the few cases in medicine overall where you can treat this patient within a minute and he's good to go home. Like this is one of those rare cases, right? We had a patient recently a month ago who had come into the medicine emerge, and he had a heart rate of approximately 210, 180 to 210, and he seemed okay, he seemed stable. We sat him down, we connected him to a monitor, and this is what he saw. Now, let me just tell you how to identify PSVT. the P wave is almost not there. Like it's mostly absent. You can just say T waves and a QRS complex. T waves and QRS complex. You can see this here, right? Just QRS complex, T waves, QRS complex, T waves, QRS complex, T waves, right? There's an abnormal T wave though, which is you can't really uh, tell if it's abnormal or not unless you've seen a lot of those T waves. The heart rate is extremely increased, the person has palpitations, and it's a narrow complex tachycardia. So the QRS complex is within three blocks, three small blocks. So it's not broad complex. Always remember that a narrow complex tachycardia is always better than a wide complex, because wide complex indicates some sort of tract involvement or ventricular involvement, and any ventricular involvement is bad. So PSVT is paroxysmal supraventricular tachycardia. Has a narrow complex tachycardia where P wave is almost absent. You will just see a very high heart rate ECG with abnormal T waves and narrow QRS complexes. Now, how do you treat this? There's one drug. Does anybody know that drug? It's just one drug. Perfect. Adenosine. Adenosine Adenosine is the drug of choice. And does anybody know how to give adenosine? The JR1 I was managing this case with was of the opinion that adenosine is given slowly over 5 minutes. Do you guys agree with that? Okay. Okay. So adenosine is a drug which has a half-life, a T half of 6 seconds. That's why you need to administer this drug and it needs to reach the heart within 6 seconds, 6 to 10 seconds of your administration. So, what are you going to do? Once you diagnose this patient as PSVT, you're going to put a cubital IV. You're going to prepare one syringe of adenosine, which is 6 mgs, and you're going to prepare two syringes of just normal saline flushes. Then you're going to inject this adenosine into that IV rapidly, following which you will administer these two NS flushes rapidly. And you're going to lift the patient's hand in the air so that the drug reaches the heart at the fastest rate possible. Did you guys get that? Can somebody confirm if you heard me? I'm not sure my internet was all right. Okay. Okay. So I'll tell you the story of what happened. The patient came in, we put it cubital IV. The JR1 thought it was supposed to go slowly over 5 minutes. We tried doing that, nothing happened. We tried doing that two, three times, nothing happened. And then I sort of said, so why don't we just give it fast? And there was another JR2 who came in, and he was like, you need to give it fast. You need to lift your hand up. So he's connected to the ECG monitor. We inject this adenosine extremely fast and then put two more NS syringes, lift his hand, and you're not going to believe this. It's the heart rate was at 180, 200. So ECG went flat, and then it just started again at normal, normal ECG at 70 beats per minute. It was just so cool. If you see it in person, you inject it and within 6 seconds, nothing's happening, and then just on the 8th second goes flat, comes back to normal, and the patient was all right. He was discharged within an hour after observation. So ideally, if you're not in the situation where you're in the medicine emerge, what you need to do as a doctor, from if you're doing your rural bond, is you need to give vagal stimulation. Vagal stimulation is given either by Valsalva maneuver or by pressing on the carotid bodies which are just beside the thyroid cartilage. You need to press it deep and you need to press it firmly and you need to massage it, because if you do it on the surface, it's not going to stimulate those bodies. Okay. And if that doesn't help, then obviously you need to go with adenosine. So adenosine, the dosage is 6 mg, 6 mg, and 12 mg. You do give these at 5-minute intervals if they do not work. Obviously, if just one dose works, you're good to go. The patient is all right. Uh, so quickly going through this hypokalemia, you're going to have a case where the mnemonic to remember this is that if you do not have potassium, you have no T. So if you have no pot, you have no T. So you're going to have U waves in hypokalemia, and T waves are either going to be flat or inverted. This is important when you're looking at a case of diabetic ketoacidosis. This is a very common case you will see in the EMS as an intern or a medical student. Uh, the patient comes in with, so look at this case which I had. The patient comes in with a low pH, which is 7.13, and a potassium of 1.9, which is much lower than the required potassium. He has tachypnea, fluid started, altered sensorium, and history of fluid intake, increased fluid intakes in the past 2 days. Now, the resident who was looking at after this case had not taken the ECG for this patient and had just started him on fluids. The reason I asked for an ECG was because I was not sure if this level of potassium would not have any effect on ECG. When we took the ECG, we found out that he did have flattened T waves, and at some points we had U waves. So these are U waves. U wave is basically something where beyond the T wave you have an upswing, which looks like the T wave is biphasic, but it's not. It's just another wave which is beyond the T, and that indicates hypokalemia, where you need to start central line infusion of potassium, ideally the rate which is usually 20 millimoles per hour, but you're really not supposed to be involved in the percentage calculation of potassium administration because potassium, magnesium, all these other electrolyte drugs are extremely cardio sensitive. So you could induce complete cardiac atony or cardiac spasm by if you calculate the wrong dosage. So always go to a resident for that. But if you have a patient with DKA and you see that his potassium levels are low, you need to take an ECG. You need to see if he has a flattened T wave or a U wave, and if he does, it needs to be started on potassium administration via central line. Patient with cardiac tamponade, you know the VEX triad. The patient is going to come in with an increased JVP, hypertension, and heart sounds, and the only thing you need to look at the ECG is he's going to have pulses, electrons, alternans. Electron alternans means that one QRS complex is going to be tall, the next one is going to be short, the next one is going to be tall, the next one is going to be short. This is essentially because of the filling difference which happens between two cycles of cardiac contraction, and it's very diagnostic of cardiac tamponade. Usually patient will have been diagnosed as cardiac tamponade on clinical grounds, and then ECG just is a good way to confirm because it could be other diagnosis like you know uh, just just an MI or another cardiac failure sort of a syndrome. Pulmonary thromboembolism is the last thing we're going to discuss. Here, there's an interesting ECG finding which you will see in your EMS, ideally in the surgical EMS, because these patients are managed surgically. Most often, these are surgical patients because they're recovering from long-term surgeries. They've been on the bed for a long time. They have a DVT, and then eventually a pulmonary thromboembolism. So these sort of ECGs you will usually find on the surgical ward rounds. Uh, the way to remember this is S1, Q3, T3. This is where you're going to have a significant S in lead 1, a significant Q in lead 3, and and an inverted T in lead 3 as well. So what do I mean by this? A significant S is basically a large depression. This S is pretty deep. A Q, like I said before, pathological Q is something which goes very deep. So Q3 and T3, where the T is inverted in lead 3 as well. Lead 3 is not supposed to have an inverted T. So AVR is usually supposed to have an inverted T. Perfect. Yeah, Shrivada. Perfect. AVR is supposed to have an inverted T, as you can see here. This is a normal inverted T. But if you see an inverted T in lead 3, you need to check for the pathological Q wave in 3. And if you have both of these, then you check for a significant S1 in lead 1. That is pretty much diagnostic of pulmonary thromboembolism, but it's usually seen only in 30% of the patients. But if you do see it, you know for sure that this is a significant large pulmonary thromboembolism. Okay, so you know what? I'm not going to go through this because I've taken 1 hour now. So you guys probably need to go Saturday night plans. This is the whole, detailed sheet with explanations and everything is available on this link I'll be sending you guys. Just there's a small 10-second feedback which you need to fill, and then at the end of that feedback, you'll get a link to download the whole notes. And I've even added some extra ECGs in that for you to practice with explanations. So you can go through those as well. I hope you guys have gotten something of value today. This has been a first for me as well, but this concept of getting people ready for the real world ECGs, or like just the real world medicine, has been something which I'm passionate about for a long time. Even this was so anyway. Yeah, I hope this was helpful for you, and I hope you guys attend any of the future sessions we have as well. I'll just put up the link on the main group. You guys can just go through that and you can download the main document. Thank you so much for coming. I've taken double of the time I promised you to keep it under, but yeah, I hope this is nice for you guys as well. Bye bye.